Welcome, everyone. We're so happy to have you joining us today at our Weight Loss Medications Unveiled webinar. My name is Amanda Knutson, and I'm the Vice President of Growth and Operations at Launch My Health, and I'll be your moderator today. Yes, that means I do accept the challenge of fielding all of your questions. I have a feeling there will be a lot of them today, so please don't be shy about using the Q&A feature. It's going to be a jam-packed hour. We are in for a real treat with our speakers today, and at the end, we will take time about 10 to 15 minutes to answer your questions. So, for our speakers today, we have Brenda Navin, a registered dietitian and the CEO and founder of Launch My Health. After spending a career in healthcare, designing and creating upstream strategies to create health, Brenda knew it was time to start her own company. That's Launch My Health, when the healthcare system could not move fast enough. She is on a mission to build and bring the food as medicine movement to life and to the masses. She's grateful that Launch My Health gets to help people every day create health in their homes. And then we also have Dr. Audrey Wells. She is a board certified in sleep medicine and obesity medicine. And first fun fact of the day, there are, for every 20,000 people in the United States who have obesity, there's only one physician trained in obesity medicine for those 20,000 people who could use help. And we're so lucky and grateful to have Dr. Wells with us today to share her expertise. So Dr. Wells is the founder of Super Sleep MD, which is an online platform for education, support, and group coaching sessions. She helps people who are struggling with obstructive sleep apnea and insomnia, and works with people who want to prioritize their sleep, manage their weight, and optimize productivity. She also consults with entrepreneurs, leaders, and professionals who struggle with getting quality sleep and managing their weight. So, for what we're going to discuss today, we are going to start off with what's trending now. Why are GLP-1 medications all the rage? Why are we just starting to hear about them? How they're connected to obesity and to lifestyle, and then what can we do about them as healthcare and HR leaders? What kind of strategies can we do to best support our people? And we'll end with Q&A. So be sure you type your questions in throughout the webinar to make sure we get through as many as possible. And this afternoon, you will receive a recording of the event with several key takeaways and even some homework and action steps that we're going to give you today. So before I kick it off to Brenda, please note that this is not medical advice and neither speaker has any conflict of interest or financial incentive with the information we're presenting today. So with that, Brenda, I'll give it to you.
Great. Thank you, Amanda, and welcome everyone on the other side of the screen. And I do just have to do a call out. I'm so excited to be speaking with Dr. Audrey Wells today. We met a couple of years ago. We're both entrepreneurs in this kind of disruptive space in healthcare, and it's really exciting to have become friends with her. And now we're actually doing a presentation together. So I'm really excited to be with her today. So to get started, first of all, this topic I think is so exciting to me, and I'm so excited to share information with you. It is like we're getting new information almost like every week. I think if you watch TV at all, if you're on social media, you're hearing stuff all the time. And last week, of course, we just had another drug that was approved, a GLP-1 medication. But to set the stage, I have to show this slide. Audrey and I both, as we were preparing for this presentation, we both had this in our decks. And this is from the CDC, and it shows the obesity rates. You can go to their website and see the rates back, decades. But what's important to highlight here, and why I put two maps on here, is that we have a great disparity amongst different ethnic groups and socioeconomic status too with obesity. So I want all of you to just kind of put that, at the forefront as you're thinking about GLP-1 medications and as you're thinking about a weight management and obesity strategy, is that we need to think about health equity, and it matters. So depending upon where you're tuning in from and the population you serve, it's an important piece of the puzzle of obesity. So what exactly are GLP-1 medications? This is like the down and dirty, simplified version for people, especially that are non-clinical. They're a class of medications that are GLP-1 receptor agonists. They mimic a natural hormone in your body called glucagon, like peptide 1. And they're not new. They've been prescribed for type 2 diabetes since 2005. That's probably when you started seeing Ozempic on the market. And the treatment, what they found in the studies is people lost weight too. So then that approval process started happening with the FDA for obesity management as well in 2014. There's two main ways. It's more complicated than this, but to simplify it, they bind to your brain's nerve cells to decrease hunger levels. You eat less. And they also delay food emptying from your stomach. So you feel fuller longer as well. So that physical kind of feeling. And it increases insulin release. So that's the main ways that they work. Now, onto the tsunami trend of GLP-1s. I mean, we have, definitely a money problem here. We have so much money being spent on GLP-1s, and that's probably why a lot of you have tuned in too. We also have an obesity crisis, as you saw from the first slide, but we have never seen this kind of trend in healthcare before, where we have the social media influence, we have celebrities, we have advertising that's happening. I don't know if you watch TV at all, but there's probably out of 8 commercials, 50% of them are a medication now, and that drives consumer demand, and people can go in and ask for medications, and that results in prescribing pressure. So physicians feel this pressure. I was just talking to a family practice doc that said, if I don't prescribe a GLP-1, they're going to get it somewhere else. So this then creates medication shortages. We have coverage conundrums. We have weight loss startups happening all over. People want to make money on this. And obesity prescribing is up 352% in February of 2023. And that's from the previous year. So they don't have the data out now as to what that is current state, but that's a big increase in prescribing. So what is all this GLP-1 buzz? Some of the interesting things that have happened most recently, Ascension, which is a healthcare system, they stopped coverage July 1st of GLP-1 medications, but they still cover weight loss services. The University of Texas, they stopped coverage September 1st, 2023. Their costs soared from $1.5 million a month to $5 million a month. So that's $60 million a year on GLP-1s alone. And for every one certified obesity physician, this is as Amanda mentioned in the intro, there are over 20,000 people with obesity. And Dr. Wells is going to talk about this, and I'm so excited that she's going to share more about what obesity is and what it isn't. And we really need more people who are qualified to treat people who have this chronic disease and have the knowledge to do that. Last week, hot off the press, many of you probably saw this, but Zepbound was approved for weight loss. And in the studies, you can see the citation at the bottom. There was weight loss up to 25%, which is getting up to the point of the same rate of weight loss that you can expect with bariatric surgery. And Dr. Wells will be talking about that. Wegovy, which is made by Novo Nordisk, they reported Q3 sales of this year in 2023 at $1.7 billion. And what's driving that is the increase in sales of Wegovy by 467% in 2023. And they've changed their manufacturing to focus on the highest doses of that now too. So I believe it comes in 3 doses, and they're just, again, focusing on that high dose. And oftentimes the cost savings, these drugs can cost anywhere from $900 to $1,300 a month, they're passed down to a PBM, but they're not passed down to the employer. So the cost is really high. Another thing that we want to highlight today, you'll be hearing us bring this up multiple times, but there is definitely an obesity bias. In a survey of healthcare professionals, 69% reported a bias on people who were suffering with obesity. And of course, we know that the general public believes that as well, and that equals stigma. And then we also hear out in the marketplace, if you're on social media, People are talking about Ozempic butt or Ozempic face and losing facial structure from muscle loss. And there is just a common conversation today. And again, the consumerism of healthcare services is so high. And a lot of times what physicians are saying, people will come in and they say they want the skinny pen. I want a prescription for that skinny pen. And just to reiterate for everybody too, these medications are designed for people who have obesity or comorbid conditions, which Dr. Wells will talk about. This is not for the person who wants to lose 10, 15 pounds. So with that is the information on the GLP-1 buzz. I'm going to toss it over to Dr. Wells, and she's going to share more about the clinical background on obesity. And I think you're going to be really surprised at some of the information that she shares too. And it's a great foundation to build a strategy from. So I'm going to stop my share and turn it over to her.
Thank you so much, Brenda.
Mm-hmm.
Let me see if I can get my screen up here. And I want to say good day to everybody. It's a fabulous day here in Minnesota, and I'm going to spend the next 25 minutes or so talking about obesity and these medications. All right. So as Brenda mentioned, I'm board certified in sleep medicine and obesity medicine. And that's the experience I'm going to draw on today to discuss these GLP-1 medications. Recently, I've given talks at a couple of national medical conferences, and the title of one of my talks is How Sleep Loss Cancels Out Weight Loss. I think that's very relevant to our discussion. I want to give you the medical definition of obesity as put forth by the Obesity Medicine Association. So obesity is a serious, chronic, progressive, relapsing, and treatable multifactorial neurobehavioral disease, wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biochemical, and psychosocial health consequences. So notice that this is a rather complicated definition for a complicated medical problem. This is because there are multiple factors that contribute to weight gain. This is truly a complex condition. And today I'm going to be explaining how this affects the new approach to obesity care as highly effective medications are coming to be available. And specifically, I'm talking about Wegovy and Zepbound. Obesity is also complicated when you think about the associated health costs. On this slide, I've listed the multiple health conditions that are made worse by obesity, and these are just some of the long-term health consequences which further amplify the need for obesity treatment. And then there are the financial costs for obesity care amounting to about $260 billion per year. Now, direct costs include surgical procedures, hospital admissions, outpatient care, laboratory testing and imaging studies, and drug therapy. And indirect costs, which are more difficult to measure, but indirect costs include missed work days and lower productivity. Sometimes this is called absenteeism or presenteeism, and higher disability and life insurance premiums, in addition to higher workers' comp claims. Now, overall, a person struggling with obesity has approximately double the annual cost of medical care compared to someone with a normal body weight and normal body composition. Additionally, the cost increases significantly with the class of obesity. And so for those who may not be aware, you can actually grade obesity severity like I've listed here. So class 1 obesity is a BMI between 30 and 35. Class 2 is 35 to 40, and class 3 obesity or severe obesity is when the BMI is above 40. Class 3 obesity is associated with a shortened lifespan, about 8 to 10 years, and significantly reduced quality of life. So a comprehensive, long-term, and multifactorial approach is needed for obesity management. And it's not just important to reduce weight, it's also important to maintain that weight loss. Additionally, a goal of managing obesity is to improve overall health. This means better metabolic health because you have more muscle than fat. You have better psychological health and lower risk for chronic disease. And finally, chronic disease outcomes are improved because you remove the synergistic effect of obesity on conditions like heart disease, diabetes, cancer, sleep apnea, etc. So what does that look like? Well, it starts with the basics and some common sense. There are really no magic beans here. At the foundation, you have healthy sleep, and building on that, you need good nutrition practices, you need adequate exercise, and you need behavioral changes that support losing weight or maintaining that weight loss after you're down to a healthier BMI. Now, these are healthy lifestyle practices, and medications sit on top. This is how you get the most value from the costs associated with medical obesity management. This is comprehensive care. In fact, this is the standard of care necessary for successful and sustainable obesity treatment. This is what we're aiming for. I want to review these one by one in a little bit more depth. So healthy sleep is at the foundation of all good lifestyle practices, because if your sleep is poor, you'll eat more. If you're not sleeping enough, you won't exercise enough. And if you feel tired all the time, behavioral change is more difficult because you're going to make impulsive choices and bad choices with a sleep-deprived brain. And sleep gives you energy, which you desperately need if you're taking in less food energy to lose weight. Now, it's known that nearly 40% of US adults get less than the recommended 7 hours of sleep, and chronic sleep loss has paralleled the obesity epidemic over the past 50 years. I like to say that the well-slept version of you is the best version of you. And in order to lose weight, you need access to that very best version. Now, moving on to nutrition. It may surprise you to know that dietary modifications, including calorie restriction, drives the vast majority of weight loss. So what I'm talking about here is nutrition in response to physiologic hunger, meaning what you eat in response to hormonal appetite signals and how much you eat and when. Now, for weight loss, people need to look for a healthy balance of protein, fat, and carbohydrates. And additionally, it's best to minimize processed food, fast food, and food containing excessive sugar. You really want to emphasize intake of nutrient-dense foods and fiber-rich foods. Ultimately, it's not just calories in, calories out. Food quality matters, and Brenda is going to be speaking more about this after I'm finished. Exercise contributes relatively little to weight loss, but regular exercise is critical for weight maintenance. However, only 1 in 4 adults actually meets the minimum exercise requirements, which is 150 minutes per week, including cardiovascular conditioning and strength training. Now, with weight loss efforts, one of the goals is to preserve lean tissue or muscle, which means if you have a better muscle to fat ratio, then you have better metabolic health because muscle burns calories much more efficiently and also has a role in blood glucose management. So preserving that muscle tissue is really important, and that's why there's no such thing as a healthy sedentary person. Behavioral change is part of obesity management because one must learn how to manage non-physiologic hunger. This means hunger in response to social pressures, in response to big emotions, or just the habit of eating at a certain time or in a certain situation. These types of hunger can override physiologic cues, often because someone is trying to numb out or just cope with stress. And it's known that people who struggle with obesity have altered reward mechanisms in response to food. So consequently, people need support, they need accountability, and they need credible education to get help changing maladaptive behaviors that maintain the obesity. So you need to overcome your sedentary lifestyle, you need to fix your sleep, and you need to carry out healthy food behaviors despite living in this kind of environment. This is the standard American diet, which is very sad. Now, there are consequences to being exposed to high pleasure foods like simple carbs and sugar and fat. And I can actually speak to this personally because since October 31st and my son's gigantic candy haul from trick-or-treating, I've had more chocolate and sugar in the last 2 weeks than I've had in the last 6 months. And this is because my food environment has changed and the candy is available. And I bet some of you can identify with this. These are behaviors that have been shown to promote weight loss, and these are kind of the ideal situation. But there are many forces that make us deviate from best laid plans, and it's just part of the human experience. The point is, without some degree of improvement in healthy lifestyle practices, it is a very heavy lift for medications alone to overcome all the factors that contribute to weight gain. Let's talk about why medications are necessary. So even if one's lifestyle is healthy, it's known that obesity may not be responsive to lifestyle changes alone. The truth is, now we know more about how weight gain causes physiologic adaptations that actively resist weight loss. So blaming and shaming someone for their obesity only perpetuates obesity bias. And I want to tell you, I've known and I've treated people who have done all the weight loss things with diligence and consistency, but they still don't see the numbers on the scale move significantly. Obesity is a chronic medical disease and it should be treated as such. Therefore, medications are necessary for obesity, just like they're necessary for high blood pressure or diabetes. Medications are indicated if a person has not lost or maintained at least 5% of their body weight with lifestyle changes, or if they have a BMI above 30 or above 27 with a weight-related health condition. And here I'm showing you a few of the oral medications for weight loss and their effect. So Contrave and Qsymia are indicated specifically for the disease of obesity. These are not GLP-1 medications and they're oral medications. And I have an example here at the bottom. If you are a 250-pound person who stands 5'8", this is going to put you at a BMI of 38, which is class 2 obesity. If you achieve an 8% weight loss with Qsymia, that's the equivalent of 20 pounds. So your BMI goes from 38 to 35. And now we figured out how to do better with medications that act like our internal GLP-1 hormone. They are much more effective. And in your body, I want to tell you that GLP-1 is normally secreted by your small intestine in response to food intake. And it does several different things, but the main effect is the messaging to the brain, I'm full. So when you compare the oral medications to the recent GLP-1 based medications, which are injected, you start to see much bigger weight loss percentages. And in bold, I'm showing you the medications for obesity treatment. They're called Wegovy and Zepbound. And it's the same as Ozempic and Mounjaro, but Ozempic and Mounjaro are indicated for diabetes. The generic names are semaglutide for Wegovy and tirzepatide for Zepbound. And if we take the example of that same 250-pound person and we give Zepbound, which has a 15 to 25% associated weight loss, that is the equivalent of 63 pounds, which is taking the BMI from 38 to 28. That's very significant. So what are you losing? First off, you lose your appetite, and that's the main effect. You also lose food reward, which is significant if you don't have the psychological support to substitute better coping behaviors around food. This is going to help you avoid emotional eating, low mood, numbing behaviors, or even just anxiety. And when you lose weight, it's not just fat. It's a combination of fat and protein. So ideally, you would be losing about 80% fat and 20% lean muscle. But that only happens if your protein intake is sufficient and you keep exercising. So I'm showing you Zepbound here on top of the healthy lifestyle practices. And I'm bringing you a quote from the New England Journal of Medicine report from the methods section in the research study that showed the response of people to Zepbound. In the methods section, it says lifestyle intervention included regular counseling sessions delivered by a dietitian or qualified healthcare professional to help participants adhere to a healthful, balanced diet with meals, with a meal deficit of 500 calories per day and at least 150 minutes of physical activity per week. This simply does not describe the average American experience. So the research study population had education, they had support, and they had accountability. Their muscle to fat ratio was good as they lost weight. And this is relevant because you can see the effect of healthy lifestyle practices in the placebo group. The placebo group had between a 3 and 11% total body weight loss. And I think this at least partially explains why there exist the terms like Wegovy face or Ozempic butt. And I worry that this is some evidence of excessive loss of the underlying muscle tissue, and it gives kind of a hollowed out appearance, which leaves you worse off metabolically. Now, what happens when a GLP-1 medication is stopped? This might be due to the reasons I'm showing here, can't afford it with lack of insurance coverage, medication shortages, and inappropriate prescribing or inappropriate follow-up. The short answer to what happens when obesity medication is stopped is that weight is regained. And in most situations, this is going to be a regain of fat, not muscle, because the average person doesn't have sufficient protein intake and exercise that supports keeping that muscle. And this sets up something called weight cycling, which is very detrimental to health. So here again, I will emphasize that anti-obesity medications are meant to be long-term to treat the chronic disease of obesity. Okay, I want to pivot and see if we can learn something with what's already been done in the bariatric surgery world. So with bariatric surgery, eligibility is based on having a BMI more than 40 or a BMI more than 35 plus an obesity comorbid condition. So bariatric surgery is very safe and has a low complication rate with proper patient selection. And you can expect between a 20 to 40% total body weight loss. And I want to pause here and reiterate what Brenda said. This is the point that GLP-1 medications, specifically the latest one, tirzepatide or Zepbound, is now overlapping with bariatric surgery outcomes in terms of weight loss. So continuing with this same example, if you're a 250-pound person who experiences a 40% weight loss with bariatric surgery, that's a 100-pound weight loss, taking your BMI from 38, class 2 obesity, to 23, which is in the normal range. Bariatric surgery has a different mechanism for weight loss, but what is seen is marked improvement in some significant chronic disease states. So you also get increased quality of life and improvements in mobility and even life expectancy. But people who have had bariatric surgery are still vulnerable to weight regain, which affects about 3/4 of those who had a gastric sleeve procedure and a little more than 1/3 of those who had the Roux-en-Y procedure. And typically, the weight regain with bariatric surgery happens in the 1 to 5 years following the surgery. When the reasons behind this weight regain were assessed, what's found is that increased energy intake can be traced back to dysregulated or maladaptive eating, noncompliance with the recommended diet or food intake, and the physiological compensatory mechanisms that drive appetite and eating. You also get reduced energy expenditure with a sedentary lifestyle and reduced lean muscle that occurs with significant weight loss in the context of insufficient protein intake and insufficient exercise. Finally, comorbid psychiatric disorders, especially depression, seem to play a role in weight gain following bariatric surgery. So where we're at currently is having 2 highly effective GLP-1 based medications in Wegovy and Zepbound. These drugs have limited availability and limited coverage. And because of how effective they've been, the demand is high and the cost is also high. I really hope I've demonstrated to you that use of these types of medications needs to be supported with healthy lifestyle practices, and all of the elements on this slide here are necessary. These are all tools that we need to have to treat obesity once and for all. The Obesity Medicine Association has recently published a universal prior authorization template for these highly effective medications. And this is something that we're going to send out to you in an email after this webinar is over. The purpose of this template is to maximize cost effectiveness, transparency, and uniformity in determining eligibility for reimbursement. It's also meant to help streamline this process by having the prior auth integrated into the electronic health records, so the clinical burden of prior auth is reduced for those who are prescribing the drugs. And finally, the hope is that it will improve the timely care for patients eligible for these medications, like Wegovy and Zepbound. Here are some of the highlights that I'm hoping you gleaned from these slides. First off, obesity is a chronic disease that requires chronic treatment. That treatment approach is built on a foundation of healthy lifestyle practices. And additionally, anti-obesity medications like Wegovy and Zepbound are powerful tools that are absolutely necessary because healthy lifestyle practices do not always work in isolation. I hope I've also showed you how weight cycling is detrimental because you get muscle loss and an unfavorable metabolic percentage as fat increases and muscle goes down. And and I also think that bariatric surgery is setting a precedent for looking at how weight gain can occur and what are the factors behind that. Now, finally, the consequences of untreated obesity are far-reaching and expensive. So whatever we can do to get control of this epidemic is going to make a big difference for those who are affected and even society at large. And Brenda, I'm going to stop sharing and send it back to you.
Great. Thank you for all those wonderful insights. And I'm going to get my presentation back up here. And we are going to jump into the lifestyle part. So as Dr. Wells mentioned, the healthy lifestyle is that pillar of which medication sits on top. And so no matter what somebody, what their BMI is or what their goals are, the healthy lifestyle component is a part of your weight and your metabolism. And this slide just really depicts all of those different components within our behaviors and what we do that impact our metabolism and our weight. And as she said too, increasing the amount of muscle mass or the fat-free mass is really important to having a healthy metabolism and healthy aging as well. So when we look at total energy expenditure, which is TEE, there's 3 components to that. It's our physical activity and just our movement throughout the day too. That's called NEAT. So like if you have a sedentary job, your NEAT calories that you burn is not going to be real high. We also have the thermic effect of food. Interestingly, that protein requires more calories to actually digest, so that thermic effect of protein is much higher than fat or carbohydrates. And then we have our BMR, which is all the calories that we need to just do what our body needs to do every day, including our brain, because our brain is working 24 hours a day and actually requires about 20% of those calories. So this is getting down to the nuts and bolts of what people actually need to do in that lifestyle bucket. This is the minimum for weight loss using a GLP-1 medication and or any medication. And I think Dr. Wells would probably agree with that. This is just what everybody needs to do. So again, we're starting with the foundation of healthy sleep. That supports everything that we do. And from there, we have 4 behaviors that people need to focus on. 1 is consuming adequate protein. 2 is avoiding nutrient deficiencies. 3 is preserving muscle mass and building muscle mass. And then the 4th is monitoring progress and having that ongoing professional support. So if we dive a little deeper into each of these, I'm just going to briefly highlight how important it is to have nutrient-dense foods. When you're losing weight, you have a caloric deficit. You're not consuming as many foods, which means you really need to focus on the nutrient density. There's not as much room for error, so to speak. So that is an important component. And because the calorie restriction might be such that you can't get all of your nutrients, you might need a multivitamin or some additional supplements. That should be determined with your healthcare practitioner, whether it's a dietitian, you're working with a pharmacist, your physician, but really looking at you as an individual person and what your needs are. This is probably, to me, as a dietitian, I feel like this is like one of the most important components because as Audrey talked about, there are so many, the loss of muscle with weight loss and the regaining and the weight cycling that happens, plus what we call as you age, like the losing muscles called sarcopenia. It's like the kiss of death as you age. So this is so important. And this is why you really need support to figure out what protein can you eat? Are you a vegetarian? There's so many components that go into this protein bucket. But besides building muscle and maintaining muscle, there's all these other things that it does too. So they're all listed on this screen. So protein is key, and figuring out what that macronutrient profile looks like for each individual is important, and it's not cookie cutter. The third is resistance training. Dr. Wells mentioned 150 minutes of exercise is the amount that you need per week. And in particular, if you carve out that resistance training at a minimum 2 times per week, 20 to 30 minutes, so that you are building muscle. Muscles need to be worked in order to grow. And so the resistance training is essential. And then the ongoing support, like I mentioned, a trained physician, a lifestyle management program, nutrition monitoring to make sure you are going to be successful on the weight loss journey. So as we kind of wind down here, it really comes down to creating your strategy. What are you going to do? I think that's the question that everybody has is what are we going to do about this? The costs are astronomical and there's like need for immediate action. So creating a strategy is obviously an important part of this. And you on the other side of the screen are doing the first step. You're educating yourself and educating decision makers on GLP-1 agonist medications and on obesity. Plus, you need to stay current with the trends. There's going to be information coming out continually about this, and what we don't know everything yet, and it will be evolving. So making sure that you stay current is going to be an important part of the process as well. Also, be aware of special interests. I mean, we have a lot of money to be made in this area too, with so many people that are suffering with obesity and they need help with it. And there's a lot of people jumping into the market too. And we have, obviously medications that they're making money on as well. So just be aware of special interests and think critically as you evaluate information that's coming out. Obviously, analyze your current strategy, your data, and your financial impact. You have to get a current understanding of what's happening in your organization. Thirdly, what is your obesity coverage philosophy, and is it aligned with your organizational values? And this is where that bias check comes in. There's a little sample up on the right-hand side. This is from Harvard, where you can do a free bias on obesity. And they also have all different ones out there that you can do besides obesity. But I would encourage you to do that, challenge you to do that, just to, level set for yourself. I did it about a year ago, and I actually did it again last night. And of course, I have a bias too. It was slight is how mine came up on this, but it's really interesting to do. And it's just a good check for yourself. And what is your short-term and long-term strategy for obesity coverage? And again, this comes into the medical equity piece and making sure that you have a strategy that helps all of your employees or all the people that you are serving in an equitable way. Evaluate your options for a comprehensive strategy. I think if there's one thing that both myself and Dr. Wells have honed in on is that medications are necessary, they're helpful, but it's all built on the foundation of a healthy lifestyle. There's no substitute for that. There's not the magic bullet with a medication. And also, obesity affects all organ systems, and that's morbidity and mortality, so death and disease. And so it is a part of why we have so many health issues in people who have obesity. So those are important things to remember. And then we have strategic cost control. So these are some actual steps that you might want to consider as you're creating your strategy. One would be to eliminate prior authorization for certain weight loss medications that are inexpensive or generic, things like metformin. So those would be the medications that Dr. Wells listed with the 3 to 8% weight loss. So reduce the barriers, make this easier for people to access. And you could implement a step up and a step down program for weight loss medications. People could work their way up to a GLP-1, and then as they lose their weight and get to maintenance, they could go down onto a cheaper medication or generic medication. So a step program could be a great way to have some cost control. You could also provide coverage for weight loss visits with a dietitian, physicians, make it, again, reduce barriers and support them in the lifestyle component. Create safeguards for quality coverage and care with experienced providers. Obviously, we have an issue with having experienced providers in the US, but also looking at how do you find those providers that have some training and experience with lifestyle management as well. Obviously, offer or integrate lifestyle management programs, nutrition, sleep, exercise, and have a layered treatment and personalization. I can't stress the personalization enough. What one person needs and another person needs are very different. I've seen that in my own practice, my own experience working in healthcare, and I think Dr. Wells would agree with that too in her seeing patients as well. And this one I think might be a surprise to people, but I find this, especially in my role now, creating a positive marketing and communications plan or approach. We need to stop with the shame and the blame and support people so that they feel empowered to improve their health and feel motivated. So this is complicated, but again, I think an essential part of this. In the last two here, we have standardized patient selection and eligibility that creates equity and also implementation easier, budgeting easier, and it's also a great way to attract and retain employees. So it is definitely time to make a plan. I hope all of you are kind of thinking about like what is your next step? What do you need to do? And for us at Launch, of course, we have a program called Launch Med. It supports people who are taking GLP-1 agonist medications or want to lose weight. Everything you can see on the screen that's included, but we work with employers, health plans, and PBMs. And also, Dr. Wells is available for consulting and helping you create that strategy for obesity management within your organization. So that's two things that we do here with Dr. Wells and Launch My Health. And what I want to do now is just I want to thank all of you for attending today. We're going to open it up for questions now, and I hope we have some good ones. And but just really excited to see what the questions are and what people are needing some help with. So I'm going to turn it over to Amanda to see what questions have come up.
Well, we've got a bunch ready to go. First, right at the beginning, Brenda, you mentioned a few organizations that actually have stopped coverage.
Yes.
On GLP-1 medications. Do you know what they're doing instead? Beyond the price point, why did they stop coverage and what's their plan?
What I read about them is that they stopped because of cost. I mean, they just couldn't sustain the cost, and they are still covering like weight loss services, seeing a physician, but they have stopped the medication coverage. So I don't know, more details on it, just what I read in the press release about it.
Another question, you kind of answered this at the end, but any additional details? For employers who want to support weight loss but can't afford to have 40% of their population on such a high cost medication, what should they be considering and what can they do?
Dr. Wells, do you want to start with that? And I can then chime in on my opinion.
Yeah, I think that the step therapy approach makes a lot of sense. So it's not the case that nobody responds to the prior the medications that had been used before, and I'm talking about Qsymia and Contrave. So until a person fails that, they could be using it for weight loss and then step up to one of the GLP-1 medications. And I think this is nice too, because it allows for personalization of obesity care and management. So if somebody starts out with lifestyle changes, adds a medication, we now have more information about what they're going to respond to and how we can better support them. And on that foundation, then add one of the highly effective GLP-1 medications if they're not seeing adequate results. So that's an example of step therapy. And as Brenda alluded to, it also works in the other direction. So for example, if someone were to lose weight on a GLP-1 medication, they could then decide to transition to an oral medication and see if that weight loss is maintained. I want to underscore all the time that obesity is a chronic condition needing chronic treatment, but we can have these tools and take different ones out depending on the situation and to help manage costs.
I would agree with that. And I would just reiterate too, the lifestyle component that, again, when you look at, I love the slide that Dr. Wells presents with the medication on top. You can always benefit from lifestyle intervention. It won't just be your weight that is impacted. There's all kinds of other things within your health that are improved from improving your sleep, from improving what you eat, from moving your body. So all of those things are going to be beneficial. And then that layer on top with the medication, with the STEP program, I think is a good plan.
Next up, Brenda, you had mentioned the alignment of organizational values and weight loss strategy.
Mm-hmm.
Can you give more information on what you meant by that?
So thinking about like if your organization values like when you look at health equity and what your organization might be doing for DEI and B, and making sure that the messaging that you send out and that you're communicating to your employees and to your customers, whatever type of business that you're in, is in alignment with what you're doing with your employees. Because that would be a real mismatch if you're saying one thing like we value equity, we value all of these things, but then you don't do that for your employees. So taking a look at what, I'm sure every organization has their values and what they believe in, and just making sure that that gut check, like what we're promoting within our benefit structure, within our benefit plan, does that align?
A couple questions about GOLO. Does it work? Did I say that right too? GOLO?
GOLO?
Mm-hmm.
What is GOLO?
I don't know.
They
just said, is GOLO safe?
I'm assuming it's a supplement.
That's what I'm thinking too.
If the question asker could type in more information, we will get on it.
Yeah.
For sleep, a couple of sleep questions. How much should a person get? Does it vary by age, BMI, lifestyle, etc.? And is it that old rule of thumb, 8 hours?
Great question. And I love where your head's at. So kudos to whoever asked this. So sufficient sleep for the vast majority of people is going to be between 7 and 8 hours nightly. In the past, you may see some things where it's the recommended amount is between 7 and 9 hours, but it may be the case that if somebody is needing 9 hours of sleep, they may be compensating for an untreated sleep disorder. So mostly I like to see 7 to 8 hours. And when you start dipping down below 6 hours of sleep, the consequences are very real. So not only do you get effects on mental health, you also get things like irregular heart rhythm, weight gain, and changes to your metabolism that affect your blood sugar. So below 6, very bad. Between 6 and 7 does have some health consequences. But for the most part, people should be getting at least 7 hours of sleep to the 8-hour mark.
A few people have said that they are not able or going to be allowing medications for their employees, covering those. What can they do instead?
And I'm assuming that
or not allowing, but not covering the cost of them.
not covering medications.
Mm-hmm.
I mean, I'll let Dr. Wells chime in on this too, but I think one thing that they can do is at least support the lifestyle component of that if they're not going to cover the medications for weight loss, and support them in other ways that even if they are choosing to pay out of pocket then for those medications, that they have the supportive piece to help them be as successful as possible.
Yeah, I would say that is incredibly important to support the lifestyle changes. And the nice thing about that is you can do it in scalable ways that are cost efficient. So programs that help to educate people about things that they eat, how much and when, how to get exercise, kind of thinking outside the box if there's joint or mobility problems. Sleep is something that I find there's a lot of myths out there about. So, educating people with programs that can be dispensed for an entire employee population is available right now. And I think in the future, there's some really interesting things on the horizon. So when Zepbound is available, I'm hoping to see the costs come down because there's going to be some competition there. One of the GLP-1 medications called Saxenda or liraglutide will go off patent in about 2026. So that'll be a generic medication that's available. There's an oral semaglutide or oral Wegovy that's in development right now. So all of these things are going to help the cost come down. And I hope that it starts with just the competition between Wegovy and Zepbound to reduce the price.
So stay on top of it because there might be opportunities to offer
Yeah,
it
and
in the future.
I was just going to say, like, keeping yourself informed and in the loop, really understanding where things are going and how it's developing is going to be helpful, because then you are kind of always developing this perspective, which is going to help going forward in making decisions about how to get the most value out of the money or out of the coverage that you're allowing for the employees.
And the other piece too, I think, is maybe even reevaluating, if you're not going to cover GLP-1s, would you cover some of the less expensive medications that could support people too? So that's I think doing an evaluation on that financial component too, especially if they're generic and really inexpensive.
Here's a more specific question. I'm sure the answer is it depends, but how many grams of protein are needed per day to maintain or grow muscle?
Oh,
Correct.
good question.
Correct. It depends.
I've learned a little bit, even though I'm not a dietitian. I learned a little bit.
Yeah, a general rule of thumb is between 1 and 1.5 grams per kilogram of body weight.
Excellent. And here's a more philosophical question. What is the general mindset of doctors who are advocating for people to take personal responsibility for their health journey?
Yeah, I think that it's a very progressive mindset, as we're starting to realize more and more that obesity is a chronic disease, and it's not just because someone is lazy or slothful. There's a lot of misconception. So the mindset of physicians is collectively evolving. And I think that there's always a competition between time and how much care can be delivered in a single medical appointment. But for the most part, I feel like physicians are coming on board to be supportive of lifestyle changes, nutrition, exercise, better sleep, stress management is a big one. So as physicians are getting educated, I hope that can also turn the tide of what patients are hearing. But oftentimes there's just a competition with how much you can accomplish in a single medical visit.
Yes. Thank you. Those are the questions we have in our available time today. And as I said before, you will all be receiving a recording of today's session and key takeaways, including that prior authorization form that's a template, the implicit or the bias test you can test yourself on, and other takeaways with what are some realistic next steps that you can take. And as Brenda shared, Dr. Wells does consulting on this, can be your partner as you are looking to build a cohesive strategy that will save cost, short-term and long-term, more long-term probably. And then Brenda and Launch My Health has the new Launch Med service for employers and health plans to tap into that lifestyle support that will be needed, as that's like the big thing that we learned is a must add for any weight loss strategy. So with that, any final words, Brenda or Dr. Wells?
I just thank everyone for joining today, and congratulations too on taking, like that step. And we applaud you for learning more about obesity and the new medications that are out there. And I want to thank Dr. Audrey Wells too for joining us today. She's an expert in the field, and we certainly appreciate her time and expertise in this area.
Thanks so much, Brenda. And I want to encourage everyone who's on this call to continue learning more about effective ways to treat obesity, and to really think about your employees and how their health might be improved, which is going to go a long way toward taking care of your organization and improving productivity. Thank you to everyone.
Thank you.